improving fall prevention for VU. So, a little bit about my topic. I started developing it about 2 years ago, and I was working in a nursing home, but I further developed it to go towards med-surg instead of a nursing home. Nursing homes just didn't really have the staff, and there wasn't a lot of research. So, falls are pretty bad in the hospital. They cost a lot of money for the hospital. So I kind of looked into what can we do to possibly prevent them, you know, other than the assessment and the fall protocol. So, and approximately 700,000 to 1 million falls occur each year in the hospitalized patient. So, and then that increases the stay for 6.9 days, and it can lead to injury and death. And it increases cost by $13,806. So I did literature review on several different articles, about 5. And the first one was a study that was directed in 2014 to find a way to improve fall prevention by evaluating gaps in current fall protocols. So they conducted interviews among nursing staff, and room observations were made, which I would include room observations and hourly rounding. And 37 of the patients, you know, were interviewed. Most of them couldn't remember even being given fall information on safety, why they were a fall risk. And I don't know if that was like confusion or what led to that. But during the observations, they made note whether or not the call light was in reach. Did the nurses follow the fall protocol? Were they doing the rounding? It didn't really specify whether or not hourly rounding was implemented, but when they did do it, it was showing like 91% noted that their call lights were within reach. 67 remembered that they had their call light if they needed assistance. 50% reported always using their call light, and 38% reported having to wait for prolonged amounts of time, which could be staffing. You know, that can be a problem too with hourly rounding. Second literature review that I did was a 30-day pilot study conducted for a 907-bed not-for-profit hospital from September 23rd to October 20th of 2013. It was focused on hourly rounding by using the Lean Sigma 6 project. And hourly rounding was conducted from 6 a.m. in the morning to 2300 at night. And then at midnight, it went to every 2 hours, which is typical for most hospitals that do hourly rounding. 2 different units were studied during a 30-day time period, and while they were studied, Unit 1, there were 3.9 falls per 1,000 patient days, and that decreased with hourly rounding to 1.3 falls per 1,000 patient days, which had a p-value of 0.006, which is a little more significant than Unit 2, who had 2.6 falls per 1,000 patient days. And then it didn't really go down, it went down like 2.5. But that could be, maybe they're more confused on that unit. You just never know what type of unit it was. And then the third study involved implementing hourly rounding on a neuroscience ward. The measures were based on 50 wards of the same trust. I don't know if trust is like in England or is that where it's at? Okay. It involved hourly rounding, teamwork, check cycles, and support coaching. And on that unit, there was a 50% decrease in falls. Right. And then the fourth study conducted was at Ronald Reagan UCLA Hospital. Their pilot study. They used traditional methods of intervention and improving fall reports. they trained clinical nurses and conducted the study from 2003 to 2014 in a 466 bed unit. And fall rates declined from 3.07 to 2.22 per 1,000 patient days, which was a pretty significant decrease because the p-value was 0.009. And then I think the last study was an intentional rounding pilot study conducted at United Kingdom in a two-phase process. It was used to decrease patient harm, and the only problem they tend to have there, didn't have a lot of evidence, was that the nursing staff was really resilient to not wanting to do rounding. So I don't know if it was like a lack of staff, but there was like a 40% completion rate of the survey by the nursing staff after the rounding was implemented, but they didn't want to stick with the rounding. A few did, but a lot didn't. My PICO question, my problem was that RNs and CNAs implementing hourly rounding to prevent falls. The intervention was the implementation of hourly rounding, and the comparison was the lack of staff to do hourly rounds or implementing other fall prevention techniques to prevent falls. The outcome would be to implement hourly rounding to decrease the incident of patient falls. And then I use the comfort theory to make sure that needs are being met of the patient, because, you know, hourly rounding, making sure that they're not in pain, that they've been pottied, their call lights within reach. Those are all comfort measures to show that we care. It's been described as relief, ease, and transcendence, according to Pettigrew. And then I had to set up a design, setting, and sample for my research proposal, and I was going to use a med-surg unit and use quasi-experimental research method to conduct my research. And then I would do chart reviews to see whether or not that decreased falls after implementation hourly rounding. It would be on a 25-bed med-surg unit with a typical patient size of 400 patients per 6 months. Huh? No, I think it's just continuing. And then the data collection and analysis, I compared the Morse Fall scale because it was developed in 1985 by Janet M. Morse. It uses 6 questions, so it's pretty simple to use by nursing staff. So on top of hourly rounding, using that to kind of guide you to see which patients are more at risk for falls. And then it uses 0 to 30 questions, and the scores range from 0 to 125. And then you can decide whether or not you might need to increase rounding on certain patients or not. And then t-test would be used from the data collected from my research through the retrospective chart review to gather pre- and post-test data. In conclusion, falls are a big problem among hospital staff and for hospitals. And implementing hourly rounding can help decrease falls. It's been proven by several research studies, although I think there needs to be more evidence and more research conducted.